الله يسلمك. نشوف شغال. شغال فيك.
خلاص نبدأ ندخل أنا. ألا باقي 10 دقائق.
I think Dr. Omar is on. Dr. Omar, is our voice okay?
Excellent. مساء الخير.
نورتنا.
الله يخليك الله يخليك أخ محمد.
We're going to start soon. Just give you an outline. Dr. Malik here is the president for the meetings at SASMBS, who is president for Eastern Province SASMBS chapter. هو
كيف
اللي
حالك
بيبدأ
دكتور؟
الكلام.
كيف حالك دكتور عمر؟ الحمد. كيف حالك؟
كله تمام. شكرا للدعوة و it's a real pleasure and honor to be here. Thank you for the invite to appreciate everybody's effort. And I'm sorry I'm was in Saudi yesterday. I was hoping to join you live, but it happened that now I'm in Qatar and in 1 hour I'm going to the airport to Kuwait, inshallah. But I didn't want to miss this, and I wanted to make sure it's live so that we can have this interactive session, inshallah.
Thanks for fitting us in your schedule.
Absolutely. I'm honored. Thank you.
أهلا دكتور عمر، مساء الخير. Actually, it is our pleasure to be with us also. I'm Dr. Saeed Al-Shimani, a GI surgeon. And thank you for your precious time. We hope, inshallah, we will have good interaction tonight with good scientific discussion. And sure, you will have valuable information for us in your lecture.
At the end, you'll see I learn from you more than you learn from me. This is the purpose of these sessions. Inshallah, we have a good session altogether.
Yeah.
أخ محمد، يعني على يمكن if there was a 1 hour difference I would have made it to الخبر.
لا سمعتي؟
It worked this way.
ما أسمع معلش.
لا خلاص هو يقول لو كان في فرق ساعة في الميتنج كان مدى يجي in person.
أوكي.
إن شاء الله بأبريل راح يكون بجدة hopefully
جدة في القصيم يمين. في جدة ولا القصيم؟
راح يكون بجدة على رد
بس لازم تجينا الشرقية يا دكتور عمر.
Well, I've never been on that side of Saudi. I have to. It's obligatory. But most of my trips are بيكونوا على الرياض. Hopefully next, I believe the World Economic Forum is having a meeting بجدة بأبريل. I'm planning to be there. Hopefully, to my understanding, the SASMBS also is having an event around the same time. So hopefully it works all together. حبيب القلب دكتور
عمر حبيبي، أولا we welcome you. Thank you so much for Malik and the team, the organizing team for this club. I welcome you. Always we're always happy to have you with us. You are now a member and always active members of our society in all activities, Umar, and we are glad to have you and pleased always to have you.
Thank you. Muhammad has the proof. I sent him my passport and the birthplace is Riyadh 1982. So there is
that's a proof. Yeah. Inshallah, and as we said, inshallah, you'll be with us in April in our meeting. It will not be in Jeddah, it will be in Qasim. And always happy to have you. And we're always proud of your performance and your really contribution to the scientific work, Riz Omar.
Allah يخليك.
Thank you so much. Go ahead, Malik. Thank you.
Yeah. Assalamu alaikum. مساء الخير. Good evening, everybody here in our meeting. I'm Dr. Malcolm Tari, Director of the Eastern Region Club Bariatric. My privilege to open this session and also to give information about our calendar of activity in 2026. It will be more than 36 sessions, virtual and on-site. Will be cover every critical and most important bariatric surgery. I am encourage our colleagues to membership, renew the membership and to receive the SMERs in future. Okay, Dr. Aid, if you want to talk about something.
Thank you so Malik. Not at all, just to welcome everybody in this meeting, and thanks for the organizing and the chair of the committee, club committee, and Dr. Malik was really leading the group. Everybody, as you know, we established this activity in different regions, and we are really happy to have leaders from Saudi Arabia, like you, and from outside, like Umar, mashallah, and the team. And we'll continue having this activity with the leadership of Dr. Malik and his team, and Dr. also Osama and their team in the society. So continue your great work, and you have the full support from the society. Thank you, Malik.
Thank you so much. Thank you so much. Dr. Mahrouz, Dr. Mohammed Mahrouz. He's the chairman of this session. Can we start, Doctor?
I will say welcome everybody, and a special thanks to Dr. Umar for accepting the invitation. I know it was last minute, and thanks for fitting us in your schedule. I'm excited for this session because it's a topic we discuss all the time. But let me start by introducing the moderators and the presenter. Honestly, I'm very, very proud to present the moderators. They're friends and scientists, and I know them on a personal level. And I know Hussam for a long time. Dr. Hussam and I go back since residency. He's a consultant and the head of upper GI and bariatric clinics at King Saud University. We went together to the same residency program. I was slightly older than him. He's doing a very good work in King Saud University, doing bariatrics and upper GI and abdominal wall reconstruction. And I'm also proud to present Dr. Saeed Shamimi, who's an old friend since medical school. He's an upper GI and hernia surgeon at Imam Abd Rahman University here in Dammam, and a colleague in Dalla Hospital in Khobar. They're two experts who can help us moderate this session. And I'm especially proud to present Dr. Umar. If it was in the 90s, we'll call him a pen pal. But now it's a social media thing. I'm sure most of you know Dr. Umar. He's a consultant and the chair of metabolic and abdominal at Mayo Clinic. He is a professor of surgery at Mayo Clinic. He also has some international work on behalf of Mayo Clinic in hernia engagement and patient engagement. He has, if you have not seen it, everyone should go to YouTube and watch his videos. He has very good videos with amazing technical points. And he's here for us today to speak about weight optimization strategies in patients with severe obesity and hernia, the devil in the details. I'll leave the mic to you, Dr. Umar. Thanks for joining us.
Thank you so much, Muhammad, and thank you, everyone. Dr. Muhammad, Dr. Malik, أو Sultan. I feel like I'm at home, literally. Let me share this. Make sure Are you seeing my slides or not yet?
Yes, we do.
Okay.
Now it's gone.
Yeah, sorry. My bad. Now better. Okay. So thank you again for the invite, and thank you for having me. And we're gonna discuss today weight optimization strategies in patients with severe obesity and hernias. The devil is in the details. It will be a broader discussion initially. There is a lot of action and technical stuff in the second part of the session. So the disclosures are not relevant. Just for the record, I am both a laparoscopic and robotic surgeon, about 55% laparoscopic and 45% robotic. I'm going to start first. The obesity and hernias are intertwined, especially now with the wave we have on the GLP-1 wave or the Ozempic wave. We've seen us as surgeons doing more and more of those complex cases where In the past, we hesitated. We kind of like used to say, "That's fine. I mean, I have a busy schedule. Why do I need to add this case that's going to take half of my day and maybe or maybe not benefit the patient?" But now we are seeing more and more of those cases coming our way. They are there. They are. We have more guidelines from the Hernia Society saying that those hernias need to be repaired, and cannot be left like this. But at the same time, checking how and when should we repair them. But again, we know that obesity is associated with hernia complications. What we don't know is a lot of things. What is the BMI threshold to operate on a hernia? What is the role now of robotics and minimally invasive repairs? Would that change the BMI? Of course, if you look at the literature, people who or hernia surgeons or specialists say there is anywhere between 35 and 40. Now we've been seeing publications. If you're doing it robotically, you can go up to 45. But we've seen complications as well. So those patients, when they get robotic surgery, that doesn't mean they're not going to have complications afterwards. We don't know what's the effect of the surgeon's skills, volume. How do we follow up these patients? We also don't know how do we manage the hernias during bariatric surgery. Today's session there's about 20 minutes on that. I think this is a great addition to this topic, because those patients, when they present, how do I manage those hernias intraoperatively? How do I place my pores? What kind of procedure do I do? What kind of complications I should expect? When to operate after weight loss, we don't know that as well. And we don't know what happens to the abdominal wall compliance after the weight loss. We take it for granted that the patient, after they lose weight, we need to get them to a BMI of 45 or 40 to be able to operate on them. But some patients will never reach that if they're starting on a higher BMI. What are we trying to achieve? Are we trying to achieve abdominal wall closure, or are we trying to achieve a BMI weight where we're not going to have any complications from or decreased incidence of complications from a wound standpoint? Options are many for those patients, dietary and lifetime modifications. Only one publication, believe it or not, from the Cleveland Clinic group on giving high protein diets for patients who need weight loss before hernia repairs. Really, it's not that effective. A couple of points of BMI, most of them end up not reaching that goal weight. Of course, now with medications, we have every day a new theory and a new medication, a new drug, and a new mode of having those medications, especially in hernias. We don't have enough data to say how their effect is going to be. I've seen some case reports recently, or a small series of about 20, 30 patients, but not enough truly to say these medications are going to help. Remember, a patient with a hernia, their hernia is acting against them. It's pushing to the outside. They can have very limited activity. Of course, the 20 and 25% on patients that are advertised on those medications on patients in randomized control studies don't apply to our hernia patients. Unfortunately, or fortunately, as bariatric surgeons, I'm going to keep it to you, but we don't know, or we cannot guarantee that those patients are going to go to the gym 5 times a day like they do in a randomized control study, and they don't have a nutritionist calling them every other day to make sure they lose weight. These are real world. In the best case scenario, as an average, we're talking about 10% with those medications. Add that to a patient with a hernia, add that to a patient with a BMI above 40, we're going to see way less than that. So are we going to able to achieve what we need to achieve in the speed we want to achieve it before this hernia incarcerates or have issues? That's another thing that we have to take into account. Of course, again, too many names and too many options that are beyond my session today. Something that is dear to Akhna Abu Sultan, endoscopic side. This is a patient of mine who had this portal vein thrombosis, ended up with this here, and unfortunately, as you can see, the stomach is part of wound. So talked to my good friend and still at that time my Mayo colleague Barham Abudaya, who performed an ESG on the patient. We got her to a proper BMI, and we ended up doing eventually a hernia repair on her. ESG options are good. We're talking about also 13 to 14% in at least the randomized control studies that are present. This is our merit study with my good friend Barham, and again 13.6 total body weight at 2 years. The other option for endoscopy is TOR-E, or trans-oral reduction. This comes in very handy because patients who get bypass have very limited options with insufficient weight loss or weight recurrence afterwards. This is a patient, Roux-en-Y gastric bypass, started with a BMI of 70, got her bypass, and then made it to a BMI of 60 plus, and we needed more weight loss, or 58, I believe. We needed more weight loss. Barham, this is ended up...
At the end of the procedure, the gastrointestinal stoma measured...
This ended up doing a TOR-E on the patient, and then the patient lost weight. And I'm going to show you eventually how much the patient lost and how she ended up doing. This is one of the most thorough reviews. I had the honor to lead that with SAGES, both the committees, the bariatric surgery committee and the hernia committee. We sat together, we gathered the information, and ended up putting it together. Again, this is the most thorough review for patients who have abdominal wall hernias and severe obesity. It talks about everything. Obesity as a risk factor for hernias. It talks about medication options. It talks about endoscopic options. It talks about bariatric surgery. It does discuss the operative planning. What can we do? What are the things we need to watch for? When do we take access? When do we take patient back to the operating room after they get the bariatric surgery, using it as a bridge for hernia repair or destination procedure? I hope at the end I can share with you that these patients have a specific protocol for me at Mayo, because I kind of try to bypass a lot of the obstacles that the system puts on us for those patients to get them to hernia repair. And we're not talking about any hernias. We're talking about these hernias. This is patient 44 years old and a BMI of 44 or 45. Presented with this, of course, had to reduce the hernia contents and do a sleeve. And this is where we get to the action, I would say. This is the essence of the discussion today, procedure choice. I mean, as you can expect, most of us, for a hernia like this, would say sleeve and leave. Get done and get out. This is a patient of mine who was referred to me from a good bariatric surgery colleague. Really, technically, he's excellent. However, he was worried doing this in his hospital with how this looks. No anesthesiologist would put this patient to sleep, especially with the pneumo, how his instrument's going to reach afterwards. And I can show you, this is a post he put on an international hernia collaboration. This is the patient before, after the procedure. You saw him intraoperatively and how much hernia he had. He got this as an injury, work-related. I ended up, see how high the hernia is. That's going to come later. That hernia, I barely had any place to place my ports. So I'm being very innovative of putting ports up and down and above the liver, and I poke with a camera through the falciform to go see what's happening on the other side and go back and forth. So these are very difficult hernias and very difficult sleeves as well. If you do them, you're doomed, and if you don't, you're doomed. Somebody has to do it. So again, you can see here, there is way less tension on that hernia here. And again, this is what this collaborative work does. I did the sleeve, sent it back to Lucian, who Dr. Pant, who ended up doing the abdominal wall reconstruction. And this is the patient after this. With the excised skin scar that you can see there. I mean, this is, if this is one of your family members, either they will continue to have that hernia more and more increase when it comes to the size and the debilitating effects of it, or you're gonna say, you know what, I'm gonna do a 3-hour sleeve or a 3.5-hour sleeve and see how can I get this patient to safety. So, however, sleeve and leave is not always feasible. This is a patient of mine who was referred to me, BMI 64, and I saw the picture by one of my partners, Dr. Horn. She said, what can you do for this patient? I said, of course, I'll do a sleeve. She said, well, she had a sleeve. So what do you do here? I ended up going in, doing, she had about 4 hernia repairs before my surgery. You can see the bowel, how it's scarred, it's stuck. I couldn't reduce the colon. I ended up doing a small counter incision, as you can see here. Apparently the colon was present overlation above the there was no way I can to reduce it, push the back and close and the top and about our procedure to post-operatively excise part of this. So even the smaller fascial defect and how she looked after we were done. Doing a common check of 400 cent, knowing that an ileocecal valve, that 300 centimeter rule does not, and I extended the common check so that the patient does acknowledge that her hernia, or I have an update for slide later as well on her. So this was the procedure choice. Port placement. Another patient of mine. Here is what the abdominal wall looks like. This is at the level of kidneys, so that's pretty high. As you can see, all of the kidneys are there. And how do I place my ports? Where can I place them? How high can I place them? This is where I push the hernia sac. I always say, doesn't mean anything where the hernia defect is. As you can see, this is a mushroom-shaped hernia. If you go on the side, you have a colotomy by default. So how do you do that? As long as I get my first trocar and then start putting needles inside the abdomen while pushing the hernia contents away to make that path safe, I put a spinal needle, aspirate while I'm going out, make sure that I can place it. You can see here, you become innovative with the port placement. This is, as you see here, the xiphoid, and these are my first 3 ports. This is less than from here to the xiphoid, and this is 50. These are some of the things that you have to think about. Valve of laparoscopy. A patient, I'm going to be presenting one in SASMBS. That's why I didn't place it off it. But this is a patient who had her stomach and duodenum. Let me repeat, the stomach and duodenum are within. So it's not an easy thing to operate, and I couldn't use it. So I had to place the 3 extra trocars within the hernia defect, lysed adhesion, as if it's another abdominal cavity within the hernia defect, pushed part of the component back into the abdomen, because if you push everything, you're going to have a loss of domain in the true abdominal cavity, and then operated partly from with those trocars and partly with those. Here, this is not an optical illusion. These are my ports aimed towards the pelvis, trying to lyse the adhesions of the duodenum and the hernia and the stomach to be able to pull back the stomach into the true abdominal cavity and then operate on the hernia. عم نزودها ولا this is all good so far?
It's good so far, Dr. Umar. Maybe if we stop the sharing and share again, because the voice has been choppy for a little bit.
Okay.
Sometimes it helps to stop the sharing and share again.
Sorry for that.
No, it's okay.
Is now better?
Yeah, it's much better. Thank you.
Inshallah. If please stop me, I can do it again partly and stop from time to time. Here is keeping the sleeve in the abdomen is super important. So this is a patient who had, as you can see here, this is her hernia is very high. You can see most of her hernia is within most of her intestines are within the hernia cavity. And the patient does have, if you noticed here, does have an ileostomy. Here you can see it's up there. So the patient needs to lose weight before we do the hernia repair. So here I didn't think that the stomach is going to be in the cavity from the scan, but when I went in, you can see that the stomach is in the cavity. So I ended up reducing the stomach back to the abdomen. And it's very important to lyse all these hernia sac attachments, all of them. I mobilize the stomach as if I'm doing a Saidi. I go to the duodenum, because if there is any of these hernia sac attachments is still going to pull that stomach up into that cavity, here they are. You can see those. These are hernia sac attachments. I take them all down so that when I do the sleeve, I then end up anchoring the sleeve to the retroperitoneum. So that the sleeve doesn't migrate back into that cavity. And as you can see here, look at this, I'm taking those bites. This is, next to the pancreas, don't go too deep. And then I anchor these so that the stomach does not get pulled into the hernia sac afterwards, so that you don't end up with a sleeve obstruction and proximal sleeve leak. I'm sometimes more innovative than suturing it backwards. This was, as you can see here, a hernia that had the liver in it. The patient had 7 hernia surgeries before, was referred to me from a good colleague from Texas in the South, came to us. I was worried what I'm going to do with this. This is exactly going to be above the stomach. The stomach is already involved. I ended up doing the sleeve, but I was very worried that even if I sutured, it's just above the sleeve. It's not here. The defect is above the sleeve. So what if it sucks it up literally like to the abdominal wall into the cavity? I brought up the liver. This is the mesentery of the colon. I sutured the liver to the mesentery of the colon so that if anything herniates, it would be the liver going into the defect like it was and not the sleeve. Complications. So these are not complication-free surgery. This is a patient who had 56 abdominal surgeries before I operated on her. I don't know which scar to look at, but I was able to place the first trocar. And here, as you can see, I'm seeing stools. That's my first trocar is within the colon. So I end up going to the other side, placing a pores from the other side, trying, as you can see here, the stomach, as you can see, when I lice adhesions is still above me. So there is a stomach and bowel above my, as you can see here, look at this. Then I find a place where I can see the abdominal wall, pass that needle, pass the trocar, and then I start working. I end up finding where that trocar was. I keep it in place to see where the injury is, and I close the hole in the colon. And then I called Dr. Abu Daya, who was at Mayo at that time, and I told him I need a colonoscopy. I'm doing a sleeve and I need a colonoscopy, and said, look, we brought you back here to do difficult cases, but I've never heard anyone asking for a colonoscopy during the sleeve. I said, I understand, but I need to make sure I didn't poke the colon from the other side. To be fair, it was my chief resident who put the first trocar while I'm standing next to him, so I didn't have really good sense. So here is the colonoscopy intraoperatively. We checked the injury. We did a leak test in the left upper quadrant, and I did end up, the patient ended up doing well from a sleeve standpoint. So other complications that can happen, I told you I'm going to get back to this case. Why was I able to get this picture? You can see the patient lost weight, and this is before her hernia surgery. I was able to get that because the patient ended up having a cholecystitis with, I had to put the PERC tube with an abscess there, and then I had to come back and do her cholecystectomy 6 weeks after her SADI before we get to the hernia repair, which was done about 5 months afterwards. So this is how I was able to get this picture for you. It wasn't immediately post-op. It was a couple of months, couple of weeks afterwards when we went back to the chole. Finally, managing the hernias. What do we do in those cases? The goal is to not leave a hernia open. Now, if the defect is too big, leave it open. Doesn't matter. If it's more than 10 centimeters, it's not going to obstruct. If you keep the sleeve in the belly, then don't worry what's going to go in the hernia. It's fine if intestines go back within the hernia, not the end of the world. Okay? Here is a case, you can see here, like the bowel keeps, and then the loops keep coming out, and more and more fat. And the moment everything goes back, you almost lose all the domain that you have, and then you can't really have a space to see. I ended up doing the hernia. This was a kind of older surgery that I did maybe in 2019. This was my first laparoscopic TAR that I did, and I did end up doing a laparoscopic TAR on her and did so well. So what do I do with this defect? It was like something around 8 or 9. So I ended up doing at that time a counter incision, and I placed a biologic mesh because she had a history of multiple obstructions before. So if the patient had a SBO before, you cannot not address the hernia, because if you get an SBO afterwards, you're going to have a proximal leak. So I ended up placing a biologic mesh like in a baseball fashion. And then when I went back, there was essentially everything was gone, and I did an official hernia repair afterwards. This is a patient who presented to me also 7 hernia surgeries. The last one was at Mayo Clinic, 11 hours. Patient had a transverse loop colostomy, had a BMI of 48, already had a sleeve gastrectomy, already getting obstructions. So what do we do here? I ended up doing a SADI as well. This is how laparoscopy is helpful in these cases, because you can go around here my instruments are around the colostomy. So this is taking the parastomal hernia contents down, and ended up doing a SADI on the patient after an extensive lysis of adhesion. You can see after I reduced this, there is a lot of adhesions in the pelvis. There is even on the scan, there was a mesh infection that I didn't go through with the discussion here, that ended up having to be taken out in the subsequent surgery. Eventually ended up getting a hernia repair and changed the to a end colostomy. It visited me about 3 months ago and post to year 2. Now, what do I do with that defect here? Here, I'll put a biologic mesh. It's really, it's going to be very hard around that loop colostomy. So I ended up bringing that omentum, and I like recog and put that omentum up in that hernia defect so that bowel doesn't go in. And in fact, I described this technique, and we have published it on a couple of patients, and more people reach out to me that they've been using it with success, as it prevents the hernia bowel going into the hernia. This was the time of the robotic parastomal hernia repair that was done by one of our colorectal colleagues. I'm going to go back to that case where we talked about the TOR-E and the patient who went down from a BMI of 70 plus to a BMI of 40 plus after a bypass and then a TOR-E afterwards. This is a open TAR. This is me operating, and you can see here the defect is more than 15 centimeters, but look at the compliance. The only reason I had to do TAR is to get sideways to get proper overlap rather than to do it to be able to close the abdominal wall. She ended up getting a paniculectomy afterwards and did well. So this is my algorithm. If the hernia is in the upper abdomen plugged with bowel, if it's lower abdomen plugged with bowel or fat and no bowel obstruction, leave it alone. If it's in the upper abdomen and the defect is open, again, your trick is this medium category. If it's too large, you leave alone. If it's a 2-3 centimeter hernia, you just put a stitch in it. But this medium-sized hernias, like anywhere between like 4, 5 up to 7 to 10, this is kind of where you are worried, especially the bigger the patient, the lower the hernia, that it's going to push things inside. And either you can do a closed primary network, especially in a patient with BMI 60 or 70, mesh. I try to avoid placing mesh and at the time of hernia surgery. This is when, again, the omental patch kind of comes handy. With bypass procedures, most of the time you have to reduce the contents to be able to do it, and we go back to the same algorithm. Those with the medium, most often, if there is omentum, as you can see, I end up shoving omentum up into the hernia. Now, when Muhammad reached out to me, he said, we want to talk a bit about paraesophageals. At Mayo, any paraesophageal above BMI above 30 gets referred to us to try to do a bypass at the same time. This is a case that I put here just for the technical part. I do these robotically, most primary cases. I do most of the revisions laparoscopically. So this was you can see here going in between the hernia sac, and I go from 9 o'clock, 12 o'clock, and then I go to the other side, try to keep that peritoneum on the hernia sac. You can see it's pretty big. It kind of meets in the middle at 12 o'clock from both sides, and it looks like a heart eventually in the middle with that kind of cleft like this. You can see it. It's literally like a heart. So I end up taking that afterwards, create a retroesophageal window, and then lift it up with a Penrose and finish the dissection posteriorly. Next to the mediastinal dissection, to be fair, it can achieve higher dissection. Robotically, love my scissors, and robotic scissors don't work. So to find the balance of what you like and what you can see in your sac is pretty thick. I take down the hernia sac, and I end up saying, okay, what am I gonna do? This patient, sorry, I forgot, did have a incident.
Yeah, sorry, Omar, if we can do that, stop sharing, share again, maybe it will help, because you started cutting up one more time.
Sorry. Sorry, I said this is primary. Are you seeing? I said this is primary. In fact, this patient had a Nissen to bypass before I operated on her. Apologies for that. So I ended up, let me go here. I ended up taking down the Nissen afterwards. This is a good example of how the scissors really doesn't work. And I do my sleeve to bypass, Nissen to bypass, and band to bypass robotically, and I do most of the complex revisions with the hernias and what you saw laparoscopically. So these are the revisions that I do robotically: are sleeve to bypass, band to bypass, and Nissen to bypass. Here I'm flipping the top stomach. You can see it. Sometimes I chop this off. It depends how it looks, but a lot of the times I do chop it off. And then I close it with this was not gonna close. I mean, it's very obvious, and you can see here I'm putting I had some vicryls on the esophagus as well. So when it doesn't close, I take 4 bites posteriorly, then I try to take anterior sutures, and even with that, try to close that anterior gap, and it didn't. It's coming in under tension. So this is a technique that Dr. Park described, Adrian Park, who at that time I was his resident, and I had the honor to be the first author, but I did not invent that technique, but I still utilize it. Whenever you have that gap and you know it's not going to work, I take down that triangular ligament. Sometimes there are small ducts. You have to be careful you don't see bile when you do that. And I bring it like a autologous biologic mesh. Look at this. It covers that defect and reinforces it into that cruise. And the good thing is that it doesn't dissolve like most of the biologic meshes. Biologic meshes don't work unless there is tissues behind them. So you cannot use a biologic mesh to bridge a gap. It will not work. There is no integration. So this is a good technique that the triangular ligament to cover that anterior defect and prevent at least early herniation. And then I ended up doing the bypass. How are we doing on time? I want to make sure that we get enough time for discussion. So you've all seen robotic bypasses. This is the rest here. We can keep it. I trim that tip, as I mentioned, and then I do the GJ. You can see here my ports are higher, knowing that I'm going to be doing a lot of mediastinal work. I'm working easier GJ, harder JJ, but you have to choose your poison. And this ended up, patient ended up well without issues. So here I'm finishing. I do PDS. For these, I use PDS except for EJ. Most of my EJs are clear because people do turn on EJs. And here is the JJ. I believe this was my last slide. Thank you. Sharing. So we're good on 40 minutes.
Yeah, we're good on time.
I hope the sound wasn't too...
I think we lost Omar. We'll give him a second. Yeah.
I'm saying I hope the voice or the sound wasn't bad.
No, it was okay. Honestly, Omar, it's an amazing presentation that you presented. I take it you concluded, or you still have?
Oh, this was my last slide. Thank you so much.
Amazing. I had the pleasure to meet you many times, but I had also the pleasure of classifying your videos that we see every now and then in HC and somewhere else. I like to give it a genre. Some of them are drama, some of them are horror, some of them are it's comedy when the fellow puts the first stroker and we pretend that it's their mistake, knowing that it could have been anyone's mistake, honestly.
I mean, I owned it. I said,
yeah.
like, this is what I was standing next to him and I was telling him, push more, push more. Definitely, it would have been me. At least I feel better that, you know, I can blame him, but no, it was completely, I owned it. There is a balance, you know, where some of us are on academia, and with these cases, you start wondering how much you can give a resident.
Absolutely.
And you start to choosing, is this part safe or this? On the scan, I felt I can still have a safe entry. Apparently, I was wrong, and as long as you recognize it,
I honestly agree with you. The balance is always difficult in these cases, and I gotta say, for me personally, the axis is always one of the most difficult steps. Not to be selfish, I have many questions myself that I want to ask, but we'll go through the audience questions. So Dr. Abdullah Ghamdi is asking about what is the incidence of hernia recurrence and mesh infection when combined with bariatric surgery. So I guess the question here, let's widen it a little bit.
Together. Yeah, should we do them together, essentially?
Yes.
I am very against the idea of doing a definitive repair at the time of the bariatric surgery. I'm against that. Sometimes we are pushed, okay, that's fine. But I'm saying definitive, because if you are trying to do a component separation at the same time, a sleeve or a bypass, or you're already burning the last bridge the patient. Patients have one shot at getting things right. Do temporizing measure, momentum, biologic meshes sometimes, maybe I used it once or twice. Doing a counter incision and closing. I mean, there is a lot of tricks to get a temporary bridging repair till eventually you go in and do a definitive hernia repair, whatever that modality is. Do I know about cases of surgeons going in, doing a sleeve and then putting a mesh in the intra-abdominal compartment? Yes. Does it work? Definitely, 98% of the time. But those 2% that get either a mesh infection or a leak afterwards, good luck. I mean, this is what you're trying to face here. It's not when it goes right, it's when it doesn't. So, and there is this, you know, sometimes we catch things on social media, some of these groups, and surgeons go around it and say, yeah, but you can use mesh in a patient with contamination as long as it's macroporous medium weight. True, if it's in the retromuscular space, which you shouldn't be doing in a patient who has obesity, because you are using their last good plane to do a definitive hernia repair. So I've seen it, and unfortunately, we have to choose what is right. And sometimes it's not easy. Most of the time, it's not. But that's what makes these patients difficult.
Yeah. Dr. Samal Sheikh is asking, Morgagni hernia and morbid obesity. What's the tactic here? Still sleeve and leave, or
it depends. You know, I've done them all. I have about 4 or 5 of these. One of them I'm presenting in SAGES in March. Patient who had a heart transplant, had a sleeve already, and came back with a pseudomorgagni and needed a bypass because for reflux. So I had to fix that. This was kind of the heart beating in front of you, because now it's literally almost in the belly next to where the morgagni is. And I've had patients who had a sleeve, and so what I choose procedure irrespective. Morgagnis are easiest hernias to deal with initially when they recur.
Great. Dr. Sultan.
Let me just say, do with these. So for morgagnis, where I'm doing a temporizing repair, I make either I suture it to the abdomen, 3 or 4 stab incisions, and bring the lower lip of the morgagni after I reduce the contents to the abdominal wall. And sometimes you can even put some pledgets, and that maybe 95% of the time works even for long term.
Yeah.
So Morgagnis are easier to deal with.
Agreed. Have you had experience with phasics mesh in the context of trying to close the defect if a plug is not big enough? Sometimes the omentum is stuck everywhere in the abdomen and you cannot use it. And speaking of the plug, there is also the question of if you have any data on the effectiveness of the omental patch as a temporizing measure, that would encourage more people to utilize the technique.
So I've used it now more than 15 times myself. I had one case where a patient presented back after about 1.5 months with a infection of that fat that I had to drain from outside. I didn't even have to open her up and then wait till the hernia repair afterwards. But yes, I mean, you are choosing, that patient had a BMI of 87 or 88. Like, so what are your options? Again, whatever you do, you're going to have, I tell patients, your chance of complication is 100%. It's just what complication we're going to end up with. So we have to be realistic with the expectations with the patient. The only time I have used phasics, it was in 2018. I had to go back on post-op day 4 and remove it because the patient was getting septic without a reason. She didn't have any fistulas or anything. And I got a call from my administrator. They said, like, you just used a $45,000 cash and 4 days after. There is no data on this period. There's a couple of industry, 3 or 4 industry papers. Most of them are from good friend Dr. Scott Ross, but a patch that has been on the market now for 15 years. So you judge.
Great. Is Dr. Saeed, I'm sure, is with us. Maybe.
Maybe I think we have to divert the discussion toward the paraesophageal and the hiatal hernia because I believe most of bariatric surgeons will not deal in our area with complex ventral wall hernia. They, will mesh it with bridge or something temporary, and they will send to acute care surgeon or plastic surgeon to do it. But most of us, we have to deal with the paraesophageal hernia and hiatal hernia, whether it is large, medium, or small. So the question, the big debate, when you repair this big hernia like the one you presented in your videos, would you put mesh or you will not put mesh? What type of mesh? Biological or bioabsorbable mesh? Because we know that in obese patient, large hiatal hernia, recurrence rate is 50%. So what you will do, does the mesh will help at least in the first 2 years while the patient will lose his weight to decrease the chance of recurrence, or you will leave it without and you will just see what will happen after that?
So I'm taking my time because I want to be fair to the literature. We have one meta-analysis, a bad one, from my group with Ben Clapp. It's a good meta-analysis of bad studies that shows that if you use a biologic mesh, you have less recurrence while the patient is losing weight. I have yet, and now, not 8 years, no 9 years of practice, Dr. Said, I'm sure I had more recurrences. I'm talking acute recurrences where you are in trouble. I had one it was a Nissan, not a true even bypass. In 2018, the act on, and one of the smallest hernias I've ever seen or was for a nurse. It wasn't one of the smallest, 2 centimeters. At the time of this, the patient came post-op day 2, came in the chest that I hit her back, reduced and the sleeve, the stomach, and said, okay, now what do I do? The patient had vomited post-op, tucked the sleeve to her chest, came to the ER. They did a CT scan. It looked okay to them, okay, and got discharged. And then in the morning, I'm looking at the scan, so I called her and brought her back. So the size of the hernia sometimes is not it is a factor, but sometimes it's not. This was one of 2 sleeve re-operations I've had to do in my lifetime so far, was on one of the smaller hernias that I had to deal with. Just to say that the size sometimes doesn't matter. Now, for these big hernias, yes, the bigger the hernia, giant hernias are associated with 50% recurrence at 5 years. And it is postulated in our meta-analysis that maybe the lower chance in what we got in that meta-analysis is the fact that patient might lose weight, and during that period, you have a biologic mesh to help them. I have yet, in my 8 years or 9 years of practice, I have not placed any mesh in the hiatus. It doesn't matter if it's the 9th redo. Have I had recurrences? Again, I'm certain I've had. But so is my friend who uses them for all his cases and calls me every time he uses it and says, well, my patient is having dysphagia at 6 weeks. What should I do? And it's a bio-A or a phasics. So everything has a price.
So now,
just to share that I share the same number of years as a practice, and I have never ever used mesh in the hiatus too.
I know you are against mesh, but just to complete this scenario. Now the foregut surgeon started to use platelet-rich plasma to reinforce the hiatus area instead of mesh. Like Dr. John Liffin, a lot of AFS members now, I think they are talking about platelet-rich plasma injection in the hiatus. Did you have experience with that, Dr. Omar? And do you observe?
I think the sane people that have worked around the hiatus know that no matter what you do around the hiatus, eventually you have a structure that is going back and forth every time you breathe like this, and you're trying to keep that in place. And I have not used plasma. I would be very suspicious if the phasics and the synthetic mesh don't work, that the plasma is gonna work. I was approached by a company, bida yani, sorry, I'm being very honest, bida. I was approached by a company that they are doing something very similar, Dr. Said. They had links, put it there. They noticed that when they had to remove the links for dysphagia, that whatever is staying behind is in fact helping the reflux. So they went and analyzed what's in that area and also came up with something very similar. لنا mesh ولنا scar. I swear, like they approached me through Mayo Ventures that they want me to lead their study, and I was like, no, inshallah kun ghaltan and we find the cure. But I mean, I doubt that 60 or 70 years now of working around the hiatus and nobody can figure it out that not something that we have missed that is that simple, that the scar after a links, for example, or an injection. But again, until there is data, I am very skeptical, as I am with phasics. I repeat that. If they give me the data, I saw the potential. You know what I saw the potential in, Dr. Said? The mesh sutures. I don't know if you're aware of the mesh sutures. It's
the Duramesh, the one called the Duramesh, I think.
The Duramesh, excellent. So I said this is perfect because it will. What I was worried about, if you get an early recurrence and that mesh becomes like a saw, مثل المنشار بتخص قصد الesophagus in half. But that I felt that yes, it is. You're using synthetic mesh. It's a bit covered away from the esophagus, so you're having all this combination that might make sense. But knowing that most of my practice is revisions, every time anything, even a plaget is left there, you have to think about the next surgeon, and the next surgeon is most of the time is you. Most of the time we take care of our own patients when they get a recurrence. So you are kind of making your life difficult afterwards.
Dr. Hussam, can you just...
I think I would just share a personal anecdote. I had one patient where I never put mesh. I'm of the school of really not believing in mesh around the esophagus. And I had one case where one of our colleagues placed the physics mesh, and I had to revise the patient a year after. And I think most of the data is encouraging in the first few years, but on the long term shows the same rate. And I think Dr. Saeed's point was, at least it will get us away from the acute phase. But you know, it's a debate that will always continue, and I'm off the school of not trying to put anything around. Dr. Sam had...
Can I add one thing that you mentioned? Anytime I have operated after a physics, it was not dissolved. Not one time I went physics case and they found the claim that it dissolves with time true.
I think it's also it plays a role where in the abdomen. I think I've had some cases where it's in the abdominal wall. It looks like it absorbs better than if you put it in within the abdominal cavity. I mean, like retrorectus versus intra-abdominal.
100%.
Dr. Samih asked an excellent question that I think is very relevant to our audience, which is at some point we reached 100. So thank you everyone for attending. The question is, do you follow the same principles for inguinal hernias and super obese?
No. Inguinals are easier to deal with now. If they are 70, yes, plus BMI, but it's way less surgical site occurrences with inguinals, and I've pushed the limit with inguinals definitely more than ventrals. The chance of recurrence in ventrals, especially incisionals, is way higher. The chance of recurrence in a good inguinal hernia repair is close to 0.5%. I tend to be more aggressive with inguinals, provided that I haven't done an inguinal hernia myself, unless I'm covering for the call for one of my partners in my division. I have not done one myself in the past 2 years.
Excellent. So now I'm going to ask a question that I really want to have your opinion on it, and our colleagues as well. You know, patients with de-innervation injury, or patients who have some component of muscle loss or sarcopenia or as such, especially those who had the previous bariatric surgery and they have a hernia, and now you're in the position of offering a revisional surgery to lose a little bit more weight. I've certainly exhumed all the options of medications in these cases, and I've been at least once, for sure, to a certain degree twice, faced a case where down the road they lose more muscle mass and it becomes a little bit more difficult. So have you seen muscle loss after bariatric surgery that will affect the integrity, and if you have any strategies to try to optimize that?
100%. I mean, this is, I think people are starting to recognize now. They even use the term Ozempic face, because you see that weight loss, people are seeing that even with the GLP medications. So it's more prominent with the bariatric surgery. The difference is that with the bariatric surgery, we have enough counseling to the patients to push for a higher protein diet to try to compensate partly for that. There are medications that are being tested on the market for anti-actin, anti-myosin kind of medications that decrease the muscle mass loss during weight loss. But yes, I mean, to your question, sometimes the muscle loss is pretty severe. You can see when I took that patient back, the laxity, part of it is because of the decreased fat, but part of it is probably because of the decreased muscle. ما يعني سوري يعني جدي بيقول مثل كلنا هلا بين بعضنا، بيقول جازي وجوزتك حظ منين بدي اجيب لك, you know. And what can you do يعني you have a patient starting with a BMI of 80 and a hernia. No matter what you do, at the end you're going to have to deal with what the patient has left you with. يعني you're choosing the lesser poison, Hussam. Definitely.
Agreed. In general, احنا كلنا we try to do our best, and sometimes this is the best that we can do. I feel like there is a role definitely for prehabilitation when you're faced with the patient who's already in a deficit prior to offering them another intervention. And I've certainly learned from my lesson, and I started to be a little bit more aggressive, learning from one of my colleagues as well as more senior colleagues who I refer to. I think it was Dr. Fahad today. a little bit more aggressive and pre-habilitating the patients while they are on the waiting list prior to their revisional surgery, to try to, because it's very hard for them to gain muscle while they are on caloric deficit, but it might be easier prior to your intervention. So, and definitely the strategy of high protein is also important. There is one question in the
we have and the ABWOL expert Kamal Muhammad was trying, I think, to add something.
Yeah, I just want to say, just for the sake of time, which question you wanted to ask, Hussam?
There's a question about the hands-on gastrojig, since we have Omar with us here today.
Yeah, we'll move to that question after.
Just for the record, I still have 15 minutes. So if you want to extend, I mean, I have to leave.
Okay, that's good. That's good. Then Hussam, go ahead with that question. Then I'll ask one last question, and then we'll finish it up.
Okay, so there is a question from the audience. I think there was an excellent session that Omar was involved on techniques on gastrojig and SAGES. So I think that's a good resource. But Omar, since you're here with us and we appreciate your time, you do hands-on gastrojig. So can you specify what's your preference in gastrojig in terms of size and type of suture that you use routinely in your anastomosis?
So I used always 3O Vicryl when I did use laparoscopically. When I started doing robotic primary bypasses too, the Vicryl have an easier chance of tearing and especially in the hands of the residents. So I shifted to PDS, and when I shifted to PDS, I like to stay consistent between what I do laparoscopically and robotically. So I changed into PDS for all my cases. So it's a PDS 3O for all layers. Can you use VLOC? Definitely. Have I ever used it on a bowel anastomosis? Never. That's a different topic. I have a different opinion on that. But until the companies take off the label that we shouldn't be using it on bowel, we shouldn't be using it on bowel. But if they're not buying into the concept of helping us and protecting us medico-legally and taking that label off their boxes, then I personally try to avoid it. Now, you saw I do it on the hiatus. Again, I'm guilty like everyone else, but I've never been failed by a Vicryl or a PDS on a anastomosis. So I have no reason to cheat on PDS, essentially.
I certainly love the luck. Mohammed, you're muted, Mohammed, I think.
Yeah. I said a PDS saves you every time. First of all, Dr. Omar, before I ask my last question, we're getting messages. Dr. Malik is getting messages. Everyone is enjoying it, and for sure, we're gonna have to do it again sometime soon. So make sure your calendar is free. I know that's an impossible.
I'm always available for Saudi anytime.
Yeah, I have one last question that was not mentioned, but we, me, Dr. Malik, Dr. Saeed, and Dr. Osama work in the same place in private, and we discussed this before. In what cases do you leave the hiatus open?
مين اللي سأل السؤال؟
أنا محمد.
خربتوا لنا بيتنا هلا صار لنا ساعة بنحكي عن بس I have left it open. Very smart question. In almost all of my EJs, whenever I'm doing a mid-chest EJ for revisions, it's against الخص بتكون صغيرة لأنه what I do is that I take a stitch from the esophagus to the crus on each side to keep it in the abdomen before doing an EJ. So I end up after finishing the EJ essentially with almost no defect. And if you don't have a true LES or true GE junction, what are you trying to prevent? The esophagus, the EJ is going to be mid-chest either way. So I keep it open so that if there is the EJ leak, it can drain into the belly. easily and not get like severe cases of mediastinitis. To say that I've left it open, it would be EJs. Otherwise, I think I'm very aggressive with closing these. Feed pathology, I didn't highlight on it today, especially on the esophagus. Dr. Saeed lost the topic of the hiatus, so I owe you this one. I wish I can study that, but where I've been burnt with the esophagus, especially in a third revision after a Nissen or second, is you go back and you start the closing posteriorly and you see that the esophagus, there is no tone in it. It's like لما يكون الاسophagus like this, it's literally like flat and wide. And these are some of the cases where I'm less aggressive of closing them because I've had to be back on patients for dysphagia and reviewed the video maybe 20 times to see what did I do wrong. What I did wrong is that I didn't notice that the esophagus is flaccid. Again, I cannot measure it, but in that video, the moment I take my first or second stitch, you can see that the esophagus went it's not a circle, it became flat. And these are patients probably have esophageal dysmotility issues and so forth. What I learned also, since we're talking about the esophagus, those cases that I have some worry about esophageal dysmotility, and I'm very aggressive with the size of the GJ, about 1.2, 1.3 centimeters. So my incidence of stenosis is about 5%. It's on the higher side. But Roux-en-Y is a restrictive operation mostly. So I with some hormonal kind of bypassing the duodenum. So that's why I'm more on the aggressive side. That said, on those specific patients, I tend to do a larger GJ because I don't want to have earlier kind of nausea, vomiting, and inability to keep foods down.
Do you have a minute for another question, or should we close?
No, please go ahead.
Okay, because someone is asking about RYGP with hiatal hernia repair, especially in patients who have reflux after RYGP. What do you do for these patients?
There is only one good publication on this by the Cleveland Clinic Group, Dr. and Jerry Dang, addressing this. I've done my share. If you are doing it for reflux, most of the time, it works, but a decent amount of time it doesn't. If you're doing it for dysphagia, that's a different story. So I choose these patients more for dysphagia reasons, because if the pouch is kinked in the chest or the way it's scarred down with the staple line it's like you see it on the scan, it's like a مثل حبة البان kind of kinked in the middle, the pouch, then straightening the pouch will work. Most of these patients, no matter how good you are and no matter how many times you suture you get like, sometimes I feel because of the weight loss and the dissection, you feel that you're gonna get the GE junction to the belly button. Then the next day or the third day, you get the CT scan for something else, and you feel that the tip of the pouch is back in the chest. Although you closed it well and everything is good, but again, the negative pressure of the thorax is very hard to overcome. And it's not necessarily that this is a hernia recurrence, يعني مش الhole by itself did not dilate. But it's like, again, you have a especially now, all of us, we are very aggressive in keeping a narrower pouch. There is a chance that it looks like more like an esophagus. It will slide up. The good thing, if you straighten it up, the dysphagia goes away. That is where I found more luck with that symptom more than the reflux itself. I hope
very good. Honestly, Omar, we enjoyed this so much. I'm sure you saw that in the excitement of Hussam and Saeed, and me too. This was one of the good sessions, and definitely we need to do something like this again with you. And the attendance, like Dr. Hussam said, reached in the hundreds. You see how people were excited, and thank you very much for fitting us in your time. We learned a bunch, and we can't wait to do it again with you in person, hopefully next time. Dr. Malik, make it happen, huh? In person.
إن شاء الله. أنا hopefully
شور إن شاء الله شور. بالعكس الدكتور عمر أبدع مرة، جدا أبدع ما شاء الله عليه.
الله يخليك.
جدا أبدع.
Thank you. Hopefully we do something like this in the main meeting in Saudi in April, inshallah.
But there's something else I need to tell you. Is like Dr. Malik said, this is going to be a repeated session for Saudi SMBS. You're more than welcome to attend, even if you're not going to present. Share the discussion with us. We'll be happy to have you at any time. If you're interested, I'm gonna start forwarding the invitations to you.
Please, absolutely. Again, if it will be in the middle of the day, عنا بالبلاد, but if I'm available, I would definitely, especially if the topic is relevant and you want me to be present, I'm more than happy to be here.
Thank you. Thanks everybody for coming. Those were very good questions. Thank you, Dr. Hussam. Thank you, Dr. Saeed. Honestly, it was a joy for all of us.
Thank you. يعطيكم العافية.
Thank you, everyone. Thank you, Malik. Thank you, Muhammad. Hope to see you guys soon.
Thanks.
Okay, and now we come just promote for the sponsor of the company, MSS, to present their presentation.
Assalamu alaikum, everyone. Thank you for inviting us and for having us for this very informative session about complex hernia and hiatal hernia, which gives me the honor to introduce MSS's MedSearch Solutions hernia portfolio. So as many of you in the room right now know, we are covering the whole hernia portfolio when it comes to complex hernia cases like the ones Dr. Omar has presented. We have our Cinecore pre-peritoneal mesh and our BioA tissue reinforcement for abdominal wall reconstruction. We have our BioA for hiatal hernia repair, which we will be extensively discussing today. And we will go over certain topics that were discussed during this discussion you were having. So many of you right now know BioA. BioA is a three-dimensional web scaffold, like we can see in this image. It's made from 67% polyglycolic acid and 33% trimethyl carbonate. It takes 6 months to absorb, and it turns into 100% type 1 collagen. Here, I would like to shed light that we call BioA a tissue reinforcement, not a mesh, because its main function is to reinforce the area where it's being placed. This material has been found in the market right now for more than 20 years. Cells are able to infiltrate through within 1 week of placing the device. We're already having vascularization going on. And eventually, like we've mentioned, within 180 days or 6 months, we'll have the complete absorption of the scaffold, and it will turn 100% into type 1 collagen, like we can see in the video right in front of us right now. Which brings us to the discussion we were just, and these data here showcase how it's turning into type 1 collagen within 6 months and how we are achieving vascularization with week 1, and the vascularization is increasing within the first month of implanting the device. And now this brings me to our discussion. To mesh or not to mesh the hiatus. And these are things we are seeing in the market, and every patient has their own unique indication. But we strongly believe that whenever we have big hernia, because like Dr. Saeed has mentioned, whenever with big hernias, we're having a recurrence of 45 to 50%, and this is a big recurrence rate. And at the same time, like Dr. Omar mentioned, there is an issue with the hiatus that we are still trying to figure out. It is a weak area, and it's the area that we are constantly and continuously moving, which is affecting as well the recurrence rate compared to ventral and inguinal hernias. And this is where we suggest the placement of a tissue reinforcement, not a mesh, to reduce the risk of recurrence or to reduce the muscle tension that's happening across the defect. Because Dr. Omar here mentioned a very important point. Sometimes even with a small hernia, we can get a high recurrence. And this goes back to the weak muscles that maybe the patient has. So reinforcing these muscles, reinforcing the crura would help us reduce the recurrence, or in case we achieved another recurrence, the repair would be also much easier because we're having stronger reinforced muscles across the crura. The BioA for hiatal hernia repair specifically comes with a U-shaped configuration to accommodate for the defect and to fit the esophagus. It comes with 1 millimeter thickness in order to take into consideration the various post-op complications that may arise from dysphagia to stenosis to other complications that you currently experience in your practice. So we do not want an extremely thick material there, and we do not want to leave a material to stay for a prolonged period of time. And studies have shown that it is providing repair with 4 times stronger reinforcement than placing sutures alone. The handling as well of BioA is very easy. Whenever we place it into the trocar, like we are seeing here in this video, it immediately returns to its original shape. And this goes back to the excellent material memory that Gore meshes and tissue reinforcement has. We have as well one side that's longer in order to place it under the liver. And for the fixation, we can fixate it with sutures on the edges, a couple of sutures, and we as well have our EFA bond and hexyl cyanoacrylate fixation glue that we can place in order to fixate the mesh or the tissue reinforcement. I would like to go to this study in order to reflect on certain points that were discussed throughout this webinar. So this study reflects the 399 patients. The 399 patients had a 44 months period of follow-up, and 56.4% of them had hiatal hernia repair with ischemic fundoplication and 42% with two-bed fundoplication. The recurrence rate here was 7.9%, and we had a variety of different sizes of defects around the hiatus. Most of them were above 3 centimeters, above 5 centimeters. So around 68% were considered medium to large defects. And we can see that the recurrence rate was 7.9%, which is significant. One important point I would like to shed some light on is the one case that developed the stenosis, because sometimes the placement of the tissue reinforcement itself is what's affecting the post-op complications with the patients. In this specific case, the BioA was placed immediately on the esophagus. What the instructions for use recommend is going at least 1 centimeter below the esophagus and placing it next to a very well vascularized area in order to enable these cells to infiltrate through and to achieve the results we want with a tissue reinforcement. And as we can see as well, which is the most important part, I believe, is the patient satisfaction post-op. So these patients had less heartburn symptoms, less dysphagia, less chest pain, and less coughing. So I believe this study reflects a reality we are currently experiencing. And right now, I would also take this time to state that we are working on a study in a hospital in KSA with more than 100 patients. We also have a recurrence around 3% with these patients. And these recurrences were mainly focused around the giant hernias, and the physicians noticed the strong crural muscles post-implanting BioA within these patients. So BioA in general is providing us with optimal porosity because of its 3-dimensional scaffold with a targeted absorption period of 6 to 7 months and 1-to-1 replacement with type 1 collagen. So we're eventually getting a 1 millimeter layer of collagen covering the crura to reduce the risk of recurrence of the hiatal hernia and to reinforce this hiatal defect along with strengthening the muscles around the crura. So thank you again for your time. I hope our message as well reached, and thank you for inviting us.
Thank you everybody here. It was an amazing meeting. The chairman of the session, Dr. Mohammed Mahrous, and the speaker, Dr. Umar, and Dr. Hussam Al-Amri, and Dr. Saeed. It was so amazing. And we'll see you next meeting and next week, inshallah, on Tuesday. Thank you, everybody here. Thank you so much.
Dr. Malik.
Thanks, Dr. Malik. If we have time just to discuss with Taya regarding the mesh.
Yes, you can ask, Dr.
If some people want to leave, yes, we have time to discuss with Taya. Taya, we have a problem now with the hiatal hernia repair with mesh. As you see in this discussion, there is a lot of debate regarding the people who don't believe in mesh and the hiatus versus people who believe that sometimes we need mesh actually. I am one of those who believe in mesh. Not for every cases, but some cases we need mesh in that area. But the problem with the mesh and the hiatal hernia I observed last few years is that we don't have a standard technique regarding the size, the shape, and the fixation of the mesh. That's what make most of the study and meta-analysis, especially the meta-analysis published 2 years back regarding the efficacy of mesh. And the problem is most of the study, they don't have a standard technique, a standard shape or size of the mesh. Most of the people, they put the mesh actually posterior, like your mesh. Some of them I saw they cover most of the diaphragm with it. And actually, what is observed in most of cases of recurrence that the recurrence usually in the 2 o'clock position, anterior left side of the diaphragm. And if you put the mesh posteriorly, that area will not be covered. You just reinforce the repair you did posterior, but that area is the site of recurrence. So I think we have to have agreement about the shape of the mesh. And that's the motion now with the AFS and DFS, European Foregut Society and American Foregut Society. They just recently started to think about that. And I think they recently, or in the near future, they will publish their recommendation regarding the shape and where to fix the mesh. And that way, I think we will have better data comparing mesh or non-mesh.
True, Dr. Said, hiatal hernia repair is one of the, yes, it's one of the most debatable topics. And like you've mentioned, not having or the lack of a standardized technique is a big issue, because right now, if we move from the hiatus and we go towards the ventral hernia repair, towards a simple case of intraperitoneal ventral hernia repair, if we do not properly close the defect, we do not properly remove the hernia sac, or we use the right mesh for this specific patient, we will develop recurrence. So establishing a uniform or the standard approach towards hiatal hernia repair with the certain indication where and when to place the tissue reinforcement. And again, we need to shed light on a tissue reinforcement, because placing a mesh is what caused all this problem and the debates among the bariatric society, because it caused placing permanent material, caused a lot of post-op complications that the surgeons suffered from, because like Dr. Omar mentioned, you are the second surgeon again with this patient. So this tissue reinforcement needs to be placed whenever we're talking about defects above 5 centimeters, because intra-op, you are able to assess that this patient is going to come back with recurrence. If a patient has weak muscles, they will come back. So we need to help the patients reinforce this weak or defected area in order to have prolonged outcomes post-op from the procedure you've just made. So we're really excited to have a standardized approach, and wherever we can help and support with that, the establishing of the standardization, please let us know.
Dr. Saeed, عندي سؤال. What is the ideally selection to use mesh or not mesh for hiatal hernia repair?
Actually, I'm speaking non-bariatric patient, because most of my patients are reflex patients. So the agreement now between the expert, there is no guidelines, but agreement between the expert is that hiatal hernia bigger than 4 centimeters, that could be indication. Recurrent hiatal hernia is another indication. And thin diaphragm, if you see the diaphragm is very thin, that is another indication. This is not a guideline, but this is, as I say, this is a motion. But the problem with these cases is, as Dr. Omar and Dr. Mahrouz said, the recurrence, when it happens, the redo is very difficult, especially the third time.
Yes.
If you have
Nice.
mesh from the previous surgery, the esophageal injury chance is very high, the gastric injury is very high, the anatomy is distorted almost. So yes, that's most of the people, they prefer to do the repair without mesh, and for the patient to see if he have recurrence to go again to put the mesh the next time, rather than to put it from the first time. But for these people, big hiatal hernia, thin muscle, old patient, and recurrence early hernia, yeah, you can put the mesh.
So clear.
Yeah, thank you.
Thank you, everybody here. Thank you for this meeting session. We'll see you next meeting. Thank you. مع السلامة.
Thank you so much.